Disclosures are on the app. So we know, this is probably everyone in this room does PAOs, has some variation of this slide in one of their talks. But we know that the natural history of the dysplastic hip is one that is quite often doomed to failure. Dysplasia is the leading cause of premature hip osteoarthritis. And while the data certainly isn't there for impingement, I think as we study this population more, there's certainly a increased risk factor for developing arthritis secondary to CAM-type FAI. So both impingement and dysplasia can predispose to arthritis. And we're advancing. There we are. This is a great study coming from the multi-center anchor group, but I think a lot of times we focus on the green circle here, the tonus zeros, tonus ones, that over a long time there is not a lot of radiographic progression proving that the PAO is one of the only surgeries in orthopedics that can actually alter the natural history of that premature osteoarthritis. Working on it again. That said, I do think we have to pay attention to the hips that do eventually fail, and it's probably not anything due to the the technique of the PAO, but it's just over time hips can develop arthritis. But focusing on this population, because after you've had a PAO or after you've had a hip arthroscopy, that puts you in a different patient population when you're considering arthroplasty. And just show of hands here, who in the room is doing total hips? So I think vast majority of people. It's not like I think most people aren't referring them out, but they're following this up. And, we want to focus on PAO improves the natural history of arthritis. Oftentimes it does not cure or entirely prevent it. So some of the longest term follow-ups, this was coming out of Switzerland, showing 1/3 survive 30 years without progression of arthritis or conversion to total hip. Other long-term studies have shown similar numbers. So the PAO, I think for most people will delay them getting a total hip, but will not prevent that entirely. And you can see from the x-rays here, a total hip after periacetabular osteotomy is kind of a different animal, and certainly something you want to be well prepared for going into the surgery. I'm not going to sort of relitigate all the data on total hips after arthroscopy, but there's a lot of papers that have shown sort of similarly an increased complication rate for a total hip that had a prior arthroscopy as well. So something to think about there. It's just a case. This is a 29-year-old. She had bilateral hip pain coming into my clinic. We'll go back. She had a the volume there was just saying that she was diagnosed with dysplasia at age 14. She had a right hip arthroscopy in 2021, left hip PAO arthroscopy in 2019. These were the x-rays that she came to see me with that we got in 2024. She did have her whole radiographic series that she brought with, so a whole lot of x-rays over many years. But just going back into the Wayback Machine, we can see this is what she looked like in 2017 on the far left. To me, signs of obvious arthritis at that time. 2018, this was after her PAO, that to me looks pretty well balanced. And then at 2020, she had the hardware removed, and you can also see the results of the femoroplasty on her right side. So this is what we have here. Clearly, we have progression of arthritis. You can see that on the right with joint space loss compared to where she was in 2017. On the left, this is the side she had the PAO on. You can still see the joint space is it's decreased, but it's still there. But when you look at the done view, you can see I think a fairly substantial osteophyte. Just show of hands here, focusing on the left. Would anyone not treat this with a total hip at this point? She's had now persistent pain for 2 years, both sides. She walks with a limp. She is miserable. But you don't have true end stage arthritis, and she is 29. Would anyone do anything differently here? All right, I like to see. This is on my board, so far so good. Again, at the risk of antagonizing one of my mentors in this room, I have sort of converted to the robotic approach to total hips. This is something that I have found very valuable for cases that have potential acetabular deformities, because with the CT scan that you get, you can then plan exactly where you want to put your implants, and then when you're doing the surgery, all the planning has sort of been done. And if you trust the robot, I almost don't even think about the cup going in unless something looks like it's off or I'm getting an abnormal reading from the robot. So I have become a convert where I think this has helped me, particularly at the beginning of practice, making sure that you are not taking out excessive bone, and you can take into account sort of post-deformity potential issues. So we replaced the right side first. That was hurting her more. Then we replaced the left side, and now she is walking pain-free and doing great. So, I love scopes. I love PAOs, but I really love the anterior total hip. I don't know, I'm certainly biased, but I definitely prefer the anterior approach, particularly if they've had a PAO or going utilizing the same planes. But that's all we got. Thank you very much.